This is the IPE patient presentation done by Ann Lamb, Jason Brooks, and Troy Agard.
Our patient is a 51-year-old Caucasian male, married, unemployed due to disability, and denied tobacco and alcohol use.
Our patient's past medical history includes diabetes mellitus type 2. He has had it for 6 to 7 years. It's been pretty well controlled over the last 6 months once he started insulin therapy. We did manage to get a look at his blood glucose logs, and he logs his blood glucose 3 to 4 times a day, and his blood glucose has not really been over 200 anymore, and it hovers right around 100. Since he started insulin, his A1C has also dropped from 11.7% in December of 2013 to 7.3%, so it's significant improvement.
The primary nursing diagnosis for patient JR is that the patient is at risk for an unstable glucose level due to dietary intake and decreased physical health status. Goal for unstable blood glucose level due to dietary intake and decreased physical health status would be the patient will acknowledge factors that may lead to unstable glucose. The major priority for goal 1 with the patient at risk for unstable glucose level due to dietary intake would be that the nurse will determine individual factors that may contribute to unstable glucose, such as morbid obesity and family history of diabetes. The rationale for this is that the family history of diabetes and morbid obesity can result in problems with glucose stability. Priority number 2 for the goal of patient will acknowledge factors that may lead to unstable glucose will be the nurse will provide information on balancing food intake, anti-diabetic agents, and energy expenditures. The rationale for this priority is that it is to increase the patient's knowledge on how to self-care for his diabetes. The second goal for a patient who is at risk for unstable blood glucose level due to dietary intake and decreased physical health status would be that the patient will maintain glucose within a satisfactory range. The first priority for the nurse for a patient trying to maintain glucose within satisfactory range would be that the nurse will review types of insulin used and delivery method. The rationale for this is it affects the timing of effects and provides clues to potential timing of glucose instability. The second nursing priority for a patient who is trying to maintain glucose within satisfactory range would be that the nurse will emphasize importance of inspecting insulin for cloudiness if it is normally clear, and monitoring proper storage and preparation when mixing is required. The rationale for this is that any deviation in these could result in affecting the insulin absorbability.
The patient has a history of hyperlipidemia, GERD, which he currently not on any medication, and hypertension, which is well controlled.
Our patient's past medical history also includes obstructive sleep apnea. Our patient said he only sleeps about 3 to 4 hours per night, and he often wakes up. Usually he says about 2 times a night, and he also has multinodular goiters.
His past medical history also include obesity, which he tried to control by losing weight, going to the gym for 90 minutes, 5 days a week, and currently undergoing counseling for bariatric surgery. His other disease is neuropathy in his wrist and feet, ranging from numbness and cold. And he also has fibromyalgia when walking, lifting arms, or moving his neck. He experienced some pain. He has tried gabapentin and pregabalin in the past, but has to discontinue it due to intolerance to the side effects.
The second nursing diagnosis is that the patient presents with impaired walking related to obesity and primary neuropathy of his feet, as evidenced by use of a cane. The first goal for a patient who presents with impaired walking related to obesity and primary neuropathy of his feet, as evidenced by use of a cane, would be that the patient will be able to move about within an environment as needed or desired within limits of ability or with appropriate adjuncts. The first nursing priority for the patient with a goal of being able to move about his environment as needed or desired will be that the nurse will note the client's particular symptoms related to walking, such as his instability walking without a cane. The rationale is that this may be affecting the client's ability or desire to engage in activity. The second nursing priority for the patient who wants to be able to move about within an environment as needed or desired would be that the nurse will encourage adequate rest and gradual increase in walking distance. The rationale for this is to reduce fatigue or leg pain associated with walking and improve patient stamina. The second goal for the patient who presents with impaired walking related to obesity and primary neuropathy of his feet, as evidenced by use of a cane, would be that the patient will verbalize understanding of situation or risk factors and safety measures. The first nursing priority for a patient with a goal of verbalizing understanding of situation or risk factors and safety measures would be that the nurse will determine ability of the patient to follow directions and note emotional or behavioral responses. The rationale is that this may be affecting the client's ability or desire to engage in activity. The second nursing priority for a patient with a goal of verbalizing understanding of situation or risk factors and safety measures would be that the nurse will evaluate the client's home environment for barriers to walking, such as uneven surfaces, many steps, or throw rugs. The rationale for this is to determine needed changes and make recommendations for client safety.
Our patient's past surgical history includes carpal tunnel release surgery. However, it was ineffective. Our patient still experiences numbness in his hands, especially when holding anything for any length of time or if it is a heavy object.
The patient has a complex family history with 8 siblings, with a history of arthritis, hypertension, diabetes, type 2, cancer in the breast and brain, heart disease, atherosclerosis, hypercholesterolemia, thyroid disease, and asthma.
Our patient is on quite a few medications. For his diabetes, he's taking Humalog. He takes 12 units sub-Q 3 times a day, but this is on a graded scale. If his blood glucose is under 150, he takes 12 units, and if it's between 150 and 214, and then every 50, it increases by 2 units. He's also on Lantus, 36 units sub-Q at bedtime. He also takes metformin, 1,000 milligrams by mouth twice a day. For his hyperlipidemia, he's taking pravastatin, 40 milligrams by mouth at bedtime. For his hypertension, he's taking lisinopril, 10 milligrams by mouth daily. He's also taking atenolol, 25 milligrams by mouth daily. He's taking cardioprotective aspirin, the 81 milligrams by mouth daily dose, and he's also on a multivitamin, vitamin D3. He's on 2,000 international units, and he's taking fish oil omega 3s, 2,400 milligrams daily. When we interviewed our patient, he had a few medical records with him. One of them was a physical exam that he had on February 19th, 2013. So from that record, we were able to collect a little bit of data. We got that his blood pressure was 118/68, his pulse was 88, his height, he's 5'6" and weighs 253 pounds. His body surface area is 2.3 meters squared. From his head, ears, eyes, nose, and throat exam, we got his head was normal, cephalic, and atraumatic. His eyes, his pupils were equal and round, and he had extraocular movement intact. His ears were normal, his throat was clear, and his tongue was also normal. His neck, it was supple without any lymphadenopathy. His lungs were normal, they were clear to auscultation. His heart rate was regular, and there was no murmur. His abdomen was soft, not tender, and there was no organomegaly. He had no masses. His extremities, there's no clubbing, cyanosis, or edema. His pulses were fine, and he did have a little bit of painful range of motion in his upper extremities, most likely due to fibromyalgia. His neurological exam, he was alert and oriented, times 3. His cranial nerves 2 through 7 were intact. His senses, he had decreased sensation on vibration and light touch in his upper extremities extending from his hands up to his elbows, as well as his feet and towards his knees. And his reflexes were 1 plus biceps and triceps and brachioradialis, and +1 in knees and Achilles.
The patient presented to us some lab data with his A1C decreasing from 11.7% in December 2013 to 7.3% in May 2014. And his TSH is within normal limit at 0.5, B12 within normal limit at 649, and total cholesterol is also within normal limit at 180.
So after reviewing our patient's medications, we came up with a medication-related problem list. The first problem that we found was that he needs additional drug therapy. His indication is lacking drug therapy. This has to do with his fibromyalgia. He's currently not on any medications for his fibromyalgia. Like we said before, he did try and take gabapentin and pregabalin, but he discontinued it due to the side effects. We rank this as a priority of high. Another problem that we found was also he needs additional drug therapy was for his GERD. He was on lansoprazole, but unfortunately with insurance issues, they no longer cover lansoprazole, so he's not on any medication at all for his GERD. And this was a priority of medium. Finally, that's the third problem that we found was that he also needs additional drug therapy. It was because he hasn't had his annual flu vaccination, which he should have gotten, and we recommend. This we ranked as a priority of medium as well.
So our group did a SOAP for the patient primary problem of fibromyalgia. Subjectively, patient reports sharp pain in his neck, lower back, shoulders, arms, legs when walking and lifting his arms. Objectively, there are 14 out of 18 painful area on the body over the past week. Patient reports patient is fatigued and waking and refreshed. He also has the symptoms for more than 3 months, and other conditions are ruled out, such as arthritis and osteoporosis. So our assessment is that JR was diagnosed with fibromyalgia and was started on gabapentin and then pregabalin in the past, but voluntarily discontinued both due to intolerance of the side effects such as nausea and raising his blood sugar up to 600 milligrams per deciliter. The patient's fibromyalgia is affecting his daily activities and quality and duration of sleep. We therefore think additional therapy is needed.
In order to help our patient with his fibromyalgia, we created a plan. First off, the goals of this therapy are to relieve his pain in his legs, arms, and neck, We're trying to relieve his fibromyalgia symptoms such as sleep problems, digestive problems that are exacerbated by fibromyalgia, and his fatigue. And overall, we're trying to improve his quality of life. So, based on the guidelines that we looked up from the American College of Rheumatology, we decided that he should ask his doctor about taking duloxetine 30 milligrams once daily for 1 week, and then increase to 60 milligrams once daily as tolerated for some. The non-pharmacological plan for fibromyalgia includes continuing to exercise for at least 30 minutes a day, 3 to 4 times a week, increase the frequency and intensity of this exercise as tolerated. Next, we decided he could try yoga or Tai Chi, a nice relaxing exercise that will help stretch his muscles and get his blood flowing and all warmed up. He can also try relaxation techniques such as meditation. He can also try acupuncture, see a chiropractor, or also receive some massage therapy. To help improve his sleep, we decided he should try and improve his sleep hygiene so that he can set a regular pattern. He should also avoid carrying heavy things so that his fibromyalgia doesn't flare up. In order to make sure that our recommendation of duloxetine for the patient is safe and effective, we had to establish some monitoring parameters. First, for efficacy, we can test to see whether or not the duloxetine is actually working for our patient by using the Fibromyalgia Impact Questionnaire Pain Score. This is a score out of 81, and we should see a decrease in the score after him taking duloxetine for a while. To monitor the toxicity and adverse effects, mostly we just want to monitor the CNS symptoms. These include headache, fatigue, dizziness, and anxiety. We're also going to we're going to schedule a follow-up appointment in 8 weeks. That's how we decided on 8 weeks because that's about how long duloxetine takes to work at its full effectiveness. We also have to make sure that we educate the patient about this new medication. So the first thing we decided was that to take the medication even if there is no symptomatic relief. Like I said, duloxetine takes a while to work at first, so it takes about 6 to 8 weeks, and he may not see any relief at first, and we just have to encourage him to keep taking it. The next thing is if he misses a dose, he can take the next dose as soon as he remembers, unless it is within 12 hours of the next scheduled dose. Then he should just skip that dose and take the dose the next day. We also said that he should report symptoms of emotional instability such as anxiety, worsening depression, or suicidal thoughts. These are side effects that he should not have to put up with on duloxetine, and it may not be the best therapy if he has these side effects. Finally, in order to monitor for serotonin syndrome, we want to tell the patient to make sure that he sees a doctor immediately if he experiences mental status changes, along with an increase in temperature or heart rate, shivering or sweating, and if he experiences muscle twitching or tremors. These are signs of serotonin syndrome, and it's a life-threatening disease, and he should definitely seek medical attention immediately.
So we have a medication-related action plan for the patient to take home. Basically, the steps that the patient should take. First, to talk to his doctor about starting duloxetine 30 milligrams to relieve his symptoms of fibromyalgia. And secondly, to talk to his doctor to change his prescription for lansoprazole to omeprazole. And third is to get a flu shot. And finally, to continue to exercise regularly and to watch his diet. And that's it for our presentation. Thank you for your time, and I hope you enjoy our presentation.